Hello, this is Dr. James Camp from Lee College in Baytown, Texas, and this is my presentation on the physiology of the urinary system. Okay, we're going to cover a few major things today. We're going to list major functions of the urinary system, trace urine formation in the nephron, list several factors affecting urine volume or composition, including some hormonal factors, explain the function and control of the urinary bladder, and finally we're going to talk a little bit about what can and cannot be diagnosed with the very common technique of urinalysis. Okay, functions of the kidneys. The most famous function of the kidney, I think if you ask most people what do your kidneys do, they would say remove wastes. Okay, and so there are three functions associated with the production of urine and the removing of wastes. The first is filtration of blood to remove wastes and excess ions. The second is elimination of wastes in the urine. And the third is regulation of ion electrolyte levels and acid-base balance. But the kidneys are also the major regulators of the blood. As we've talked about in some previous chapters, they produce and release EPO, or erythropoietin, which regulates the amount of red blood cells in the blood. They produce calcitriol that helps the intestines absorb calcium, so they help regulate blood calcium. And they produce renin, which is a major regulator of blood pressure. Which brings us to the second point, that the kidneys regulate blood pressure via the renin-angiotensin system, and also in the other direction, they help regulate high blood pressure in response to a hormone called ANP that we'll talk about later. Finally, the kidneys have a very minor role in metabolism in that they can produce new glucose under starvation conditions. Okay, so we're going to start with a quick little review here, tracing the blood flow into the kidney. We start, of course, with the renal artery that supplies the kidneys. This splits into a set of segmental arteries, which themselves split into a series of interlobar arteries. Okay, you can think of each pyramid of the kidneys as being sort of a lobe, and so the you have a segmental artery and then a couple of interlobar arteries coming off of that. At the top of the interlobar arteries branch off in little arches or arcs, the arcuate arteries, and then off of those are a sequence of cortical radiate arteries. At least that's sort of the name I learned for them. Other textbooks these days are calling them the interlobular arteries, as if you can imagine each little space up here being a lobule of the kidney. So these are interlobular. Okay, if we zoom in on one interlobular artery, off of that come afferent arterioles, which go to a first capillary bed called a glomerulus. Then an efferent arteriole carries blood out of the glomerulus to either the vasa recta, which surrounds the nephron loops, or to a network of PTCs, peritubular capillaries. Okay. Then on the way out of the kidney, we have interlobular or radiate veins. We have arcuate veins, and we have interlobar veins. There are, as far as I know, no segmental veins, and so we go from there right back to the renal veins that drain the kidney completely. Okay. Now that we know how blood gets to the to and around the part of the kidney, the nephron, where urine is processed, we're going to talk about urine production. Okay. Blood is filtered from the glomerulus to what's called the capsular space of the glomerular or Bowman's capsule. Okay, it's one of those dead people's names that they're trying to get out of biology these days. Used to be everybody called this Bowman's capsule. Now they're trying to use glomerular capsule. Okay, the fluid that exits the blood here is called filtrate and is more or less equivalent to blood plasma minus proteins and lipids. I don't know why I have a second blank there. Proteins, because they are too large to make it through the filtration slits in the between the podocytes, okay, and through the filtration membrane. Lipids, because they're not water soluble, so they have to be transported usually by proteins. So any lipid soluble elements of the blood are not going to be filtered in the kidney. Okay, from here the filtrate flows into the proximal convoluted tubule, and now the fluid is called tubular fluid, which is not quite exactly filtrate, and it is not quite exactly urine yet. Here, nearly 100% of nutrients are reabsorbed into the blood, including glucose, except in cases of hyperglycemia. If you already have too much glucose in your blood, you're going to overwhelm the glucose transporters in the PCT, and so you're going to end up with glucose in the urine. Amino acids are taken up at this point, and ketone bodies, because they are things your body is capable of living off of using as nutrients, are also absorbed in nearly 100%, except in cases of ketosis. That is, if you have, just like with glucose, if you have too many ketones in your blood, you're going to overwhelm the transporters here. Also reabsorbed here are about 65%, almost 2/3, of water and electrolytes. And when we discuss electrolytes in this lecture, we're generally going to be referring to sodium, potassium, and chloride. Okay. Also reabsorbed here is about 80% of blood buffering agent bicarbonate, which y'all should be getting used to hearing about by now. That's HCO3-. That's our major, it's what we call a weak base, and it's the major weak base in the blood that buffers carbonic acid. And there's an unknown percent of minerals, calcium and phosphate. This tubule also secretes wastes and toxins into the fluid, including nitrogen wastes, urea, uric acid, and ammonia. These are byproducts of protein breakdown. When you burn proteins for fuel, the carbon and hydrogen and oxygen in the protein get burned just like a carbohydrate would, but the nitrogen part of an amino acid gets spun off as ammonia, which, in case you aren't aware, you're not really supposed to guzzle ammonia, right? So ammonia gets quickly converted typically into urea and uric acid, and these get cleared from your blood in the kidneys. Creatinine is a breakdown product of creatine, of the substance that your muscles use for energy, and in fact is secreted, creatinine is secreted in such a constant, consistent amount into your urine that it's used as a calibration for quantitative urinalysis. If you're trying to figure out exactly how much of something is in the urine, you compare it to how much creatinine there is. And finally, certain drugs with renal clearance. Okay, if you learn about pharmacology, you'll learn that some drugs have hepatic clearance and some drugs have renal clearance, and some of the drugs with renal clearance just come out in the kidneys passively, but some are actively secreted in the PCT. Okay. From the PCT, fluid now flows into the nephron loop, where the theme here is balancing water and electrolyte absorption. So in the descending limb, 20 to 25% of water is reabsorbed by osmosis. So as we're going down the nephron loop, we have osmosis of water into the vasa recta. Okay, remember we've got the vasa recta wrapped around here. And then in the ascending limb, um, 20 to 25% of electrolytes are reabsorbed by passive diffusion, again, into the nephron loop. Now, what's cool about this system is the nephron loop runs, the vasa recta runs in exactly the opposite direction of the nephron loop. So as blood is flowing down the vasa recta, it's picking up more and more concentration of electrolytes, so that by the time it's coming up here, it's very concentrated electrolytes. And what does water do? Well, water osmoses from a lower concentration to a higher concentration, so that pulls water out of the nephron loop into the vasa recta here to dilute the blood on its way back up. As this happens, water being drawn out of the vasa recta, water being drawn out of the nephron loop means there's a higher concentration of salt at the bottom of the nephron loop, which is naturally going to diffuse into the blood because solutes flow from high to low. So this is called a counter-current multiplier or counter-current exchange system. So this is facilitated by counter-current flow of blood in the vasa recta. I learned about counter-current exchangers in my chemical engineering class when I was an undergrad. We talked about them, as if humans had just invented this thing out of nowhere, but in fact, the kidneys have been using counter-current flow for millions of years. Okay, third, fluid flows into the distal convoluted tubule, and here the theme is control of filtrate and blood concentrations by hormones. Okay. Water, good old water, is reabsorbed in times of dehydration under the control of the hormone ADH, antidiuretic hormone. Sodium is reabsorbed or not to control blood pressure under control of the hormones aldosterone and ANP. We're going to talk about these in just a minute. And aldosterone also directs secretion of the mineral potassium. We want to actually get rid of potassium from our blood because potassium in our blood is not good for us. Finally, the mineral calcium is reabsorbed or not under control of the hormones PTH, which causes the reabsorption of calcium, and calcitonin, which causes our body to dump calcium because we've got a high blood calcium to begin with. Finally, blood pH is controlled by either reabsorbing H plus and secreting HCO3 minus, or vice versa. We might secrete H plus and reabsorb HCO3 minus if we reabsorb H plus if the blood needs more acid. We reabsorb HCO3 minus if the blood needs more base. Okay. When the fluid enters the collecting duct, it is now officially urine. Okay, you can't see that. Urine. One last dose of good old H2O is reabsorbed under control of the hormone ADH, antidiuretic hormone, as we've mentioned a couple of times now. The CD ends in a papillary duct, which empties through a renal papilla, and from here fluid flows into a minor calyx, which empties into a major calyx, and finally into the renal pelvis itself. Okay, fluid leaves the kidney via one of the ureters and then flows into the urinary bladder. Finally, in a process called micturition, or some nursing textbooks call it voiding, urine leaves the bladder through the urethra. Okay. This is a good time to pull out your lab sheets for your lab book and work through the page on tracing what is added to and removed from the urine at each point. We'll cover that in my class in a online session, a Blackboard Collaborate session. All right, so you should be able to fill out this renal physiology recap based on what we just did. So I'm going to leave this for y'all to figure and move on. Okay, so major hormones that control urine output. Antidiuretic hormone, or ADH, also called vasopressin, because it has something to do with blood pressure, is a hormone produced by the hypothalamus when the body is dehydrated. Okay, if you think of a diuretic as something that makes you produce more urine, an antidiuretic hormone is something that makes you produce less urine, or put less water in your urine. So it helps your body conserve water when it's dehydrated. Dehydration is measured by the hypothalamus as low blood osmotic pressure. Okay. ADH allows water to be reabsorbed mainly from the collecting duct. This is going to decrease the volume of urine and increase the amount of water in the body. The second major influencer of urine output is the renin angiotensin aldosterone system. Okay, so to understand this, we have to start in the liver. Okay, the liver constantly produces angiotensinogen. Like all other molecules that we talk about in this class that end in ogen, this is an inactive form of the hormone that's produced pretty much constantly and is constantly present in your blood. Okay, angiotensinogen is converted to angiotensin 1, which is another inactive form, by renin, okay, which is secreted by the kidneys when blood pressure or flow rate through the juxtaglomerular apparatus is too low. Okay, the JG cells secrete the hormone renin. Okay, so renin causes us to have in our blood angiotensin 1. Angiotensin 1 converts to angiotensin 2 by a molecule called angiotensin converting enzyme, or ACE, which is secreted by the lungs. So the lungs convert angiotensin 1 into angiotensin 2 by secreting angiotensin converting enzyme, or ACE. Okay, one of the things they do for people who have high blood pressure is they give them ACE inhibitors. Okay, angiotensin 2 just by itself causes blood vessels to constrict, which raises blood pressure just by itself on a short-term basis. Angiotensin causes the adrenal cortex to secrete aldosterone, okay. This hormone causes the distal convoluted tubule and the collecting duct to reabsorb sodium, which pulls with it chloride and water. More salt water in the blood means higher blood pressure. So the ultimate effect of the renin-angiotensin-aldosterone system, or RAS, is to raise the blood pressure when the body is going through hypotension. Hypotension is a serious concern because you can go into something called hypovolemia or even hypovolemic shock, where your body can't circulate its blood effectively anymore. However, the more serious problem in America these days, the more common problem, is high blood pressure. High blood pressure is responded to by a hormone called atrial natriuretic peptide, or ANP. Okay, also called atrial natriuretic hormone, or ANH. As the name suggests, it's secreted by the atria of the heart when these chambers have been stretched by high blood pressure. Now, the name natriuretic comes from the word natrium, which is the Latin for sodium, and that's why we have Na as the abbreviation for sodium. So natriuretic means we're going to block sodium reabsorption to increase the amount of sodium in the urine. So it blocks sodium reabsorption in the DCT and collecting duct, and this is going to increase the volume of urine, decrease the amount of water in the body, and decrease blood pressure. Okay, so now we know how urine is made. We know that urine makes it to be stored in the bladder. Let's talk real briefly about how that urine gets out of your body. Urine storage and micturition are controlled mostly by your autonomic nervous system, so sympathetic and parasympathetic nerves. Storage of urine in the bladder is controlled by the sympathetic nerves, your fight or flight nerves, because you can imagine that if you were, running from a bear in the woods, you wouldn't want to have to stop and take a leak at that moment. So the sympathetic nerves cause the detrusor muscle, the muscle that empties urine, to relax, and they cause the internal urinary sphincter, the muscle that holds urine in the bladder, to contract. When the bladder is 200 to 300 milliliters full, stretch receptors in the bladder wall initiate the micturition reflex. And that reflex center, strangely enough, is located in the pons of the brainstem. We associate most of these unconscious regulations of our body with the medulla of the brainstem, but the reflex center for micturition is in the pons. Now, your homeostatic parasympathetic nerves cause the detrusor muscle to contract, trying to decrease the size of the bladder and squeeze out urine, and the internal urinary sphincter muscle to relax. The person then has the choice of either consciously relaxing or consciously contracting the external urinary sphincter muscle using what is known as the pudendal nerve. You may choose to contract your external urinary sphincter muscle long enough to make it to a suitable place to, void your bladder, and then you may choose to relax it once you're, pointed at an appropriate toilet or bush or something like that. The pudendal nerve then is sort of the nerve that it's one of the last nerves that your body gains conscious control of, and that's why potty training happens after your first year of life, not, as soon as you're born. Okay. Second part of my renal physiology recap, what are some things you shouldn't find in healthy urine? If you found glucose in your urine, that would indicate that you're overloading those glucose transporters in the PCT, and so that would indicate hyperglycemia. And some good indications, that might be diabetes mellitus, the type of diabetes that gets all the press. Might indicate gestational diabetes, which is why glucose is one of the two things that's very commonly tested in pregnant women. The other thing that's constantly tested in pregnant women every time they go in for a prenatal visit is protein in the urine. And this could indicate a whole lot of problems. It could indicate total kidney failure or early stages of it. But it's perhaps most likely to indicate hypertension, which could indicate something called preeclampsia in pregnant women, which is a very serious problem that often requires bed rest to prevent premature labor. Okay, the other thing that you might find in unhealthy urine that you wouldn't find in typically healthy urine are ketones. Okay, and this indicates ketosis. Okay, which used to be almost exclusively a sign that the patient was literally starving. Okay, or that the patient was diabetic and going through diabetic ketoacidosis, which is possibly deadly. Today, we get a lot of false positives from ketosis from people on these so-called carb starvation diets or low-carb diets. I personally don't recommend the low-carb diet, except as a very short-term kind of losing a lot of weight in a hurry that you could then switch to a more sustainable diet that would keep the weight off. But I've heard from medical sources that 2 weeks is about as long as you would ever want to be on a ketogenic diet. Beyond that, you start to do damage to your body with all of the excess ketones. Okay. If we see leukocytes in our urine, that would probably indicate a urinary tract infection. Okay. The leukocytes would be deliberately crossing blood vessels to get into your urinary tract to try to fight that infection. If, on the other hand, we saw erythrocytes in your urine, that might indicate a few different things. It could indicate kidney damage, because the red cells are leaking into the nephron, into the filtrate when they're not supposed to. It could indicate kidney stones that are simply causing causing the ureters to bleed and allow blood into the urine. Crystals. Well, there are a whole bunch of different things that could cause crystals in your urine. A UTI, again, might cause clusters of bacteria that appear crystalline in your urine. Severe diabetes might cause clusters of sugar molecules to form, sugar crystals to form in your urine. And high calcium in your urine, which might come from drinking a lot of hard water, for example, might indicate early stage kidney stones that are working on forming. Abnormal color. Again, you could have a lot of different abnormal colors. Sort of greenish color might indicate a UTI. A sort of reddish color might indicate that there's some bleeding in your urinary tract that's causing blood to get into the urine. However, a lot of urine colors are simply indicated by, or simply caused by, eating some strongly colored food, and the food pigment makes it all the way to the kidneys and out in your urine. Okay, so this is a good time to do the Urinalysis Lab that we're going to be posting on Blackboard for y'all to do. You're going to be testing 3 patients who each have some diagnosable problem, and then a control patient to show you what a standard urine dipstick should look like if there's no problems with the patient. Okay, then finally, just some things that you'll want to pause this slide and just read through this to look at what some of the false positives and true positives are in urinalysis. All right, so thank you for watching this presentation, and Good luck in your A&P course.